Lastly, I just wanted to add some extra graphs on here as well as little tables. So what I found on our book on Understanding Pathophysiology, the mechanisms of oliguria in acute kidney injury. So what happens in that pre-renal stage, intra-renal stage, and the post-renal. And as you can see, pre-renal, it gives you specifically, little arrows of what happens. So we have decreased renal blood flow, which eventually will lead to the hypoperfusion, which means decreased GFR, and then eventually it leads to all of these problems, like increased aldosterone, ADH, increased distal tubules, and sodium and water reabsorption eventually will lead to oliguria. In intrarenal, we see that there's some kind of injury occurring, apoptosis, necrosis, and then it's going to see to cast formation. Eventually will cause the intratubular obstruction, and then we have the pressure again, then we have all the tubular back leak, and then we have the decreased GFR, and then we will oliguria occurs. In the post-renal, we have a bilateral obstruction, so meaning both sides, okay? So not just one area, both areas obstructed, again, like a catheter or anything that goes inside. This eventually releases. So what happens is swelling. Swelling is not going to allow perfusion, so we're going to have renal vasoconstriction because it's the swelling. Then eventually we're going to have cellular and interstitial edema, and then we're going to have, again, decreased GFR, which is going to lead to less urination, so oliguria. On the other table, I wrote, I have the factors, I got them from our book. So the factors representing progression of chronic kidney disease. So what's leading up to chronic kidney disease? And this goes specifically more of the patho of the proteinuria, glomerular hyperfiltration. So what's causing the creatinine in urine, urea clearance, sodium and water balance, all the factors that lead up to that chronic kidney disease. I like this table because it specifies them even more, and it's less having to read versus something more simple, simple. So it has it on here, it has the acid base. It lets in early renal insufficiency, acid excretion and bicarbonate reabsorption are increased to maintain normal pH. Metabolic acidosis begins when GFR rates reaches 30 to 40%. So again, our kidneys are trying to work to get rid of all these things. Then we also get dyslipidemia. So chronic hyperlipidemia may induce glomerular and tubular interstitial injury. Because why? Well, it's decreasing it's vasoconstricting. So it's contributing to the progression of chronic renal disease. So if you want to go over this, and I don't want to bore you anymore with me talking. Overall, I hope this has a lot of information for you, and if you guys have any questions for us, just let us know.